where we'll be discussing how different states are using 1115 waivers to advance health equity. And our first, my name is Sweta Haldar. I am short South Asian person, and I use she, her, and they, them pronouns. And our first speakers, and I work at Families USA as a senior policy analyst, and I'll be moderating this session. So the first speakers on this subject will be giving a presentation on innovative community partnerships and programming as a pathway to reducing health disparities. And they're coming here from New York, and they are Katherine Rogala, who works for the Finger Lakes Performing Provider System, a senior director of program management. Katherine leads the execution of organizational strategy for large-scale healthcare system transformation efforts. She's an accomplished healthcare executive with governance, strategic planning, business stewardship, operations finance, and organization design experience. And we'll also be joined by Pennise, who works at Common Ground Health and has a wide range of experience planning, executing, and evaluating initiatives to improve community health for a variety of populations, including the healthcare workforce, older adults, rural residents, and people with disabilities.
Good afternoon. So I'm Melissa Pennise. I am a white woman with dark hair wearing a floral dress and I'm Canadian with Bleser. I use she, her pronouns. So I just want to first own the fact that our title does not actually reflect that we're talking about healthcare workforce initiatives under the New York 1115 waivers. Quick agenda, I will introduce Common Ground Health and our regional consortium on healthcare workforce. And then I will pass it on to my colleague, Katherine, who will introduce Finger Lakes Performing Provider System and the workforce programs they currently have underway, as well as a very quick blip into what we are anticipating under the new New York 1115 waiver. So Common Ground Health, we were founded in 1974. We are one of the nation's oldest and most effective regional health planning organizations. And what we do is we bring together leaders from multiple sectors in this 9-county region that is highlighted on this map. And you're really working to bring leaders together with community members to find common ground on community health issues. We look at local and national and state data. We look at research, best practices, as well as community need to identify strategies to improve population health. One big theme I think we've heard over and over for the last 2 days is the importance of collaboration. And so this network map shows over 700 individuals, 240 organizations, and 24 cross-sector tables that our organization convenes on a variety of health issues. So the healthcare workforce is one of our convenings that we've been doing for a long time. And so what this graph is showing, this is for our 9-county region, really sustained increase in healthcare jobs since 2000, followed by a 5.3% decrease during COVID. So you can see we've got a little bit of this upward blip, but we are still experiencing a big gap in the kind of healthcare workforce that we need to deliver services. What this graph does not show is the demographic context that is driving increased demand for health services. So again, I think I've heard this a couple times in the last few days. We have an aging population. In our region, we have 2 populations that are going to grow over the next few years, and those are 65 to 84-year-olds and 85 plus. At the same time, we are seeing a decrease in the working age adult populations. And so this is really concerning for a couple of reasons. One, it affects the pool of potential healthcare workers that we have to draw from. And 2, everybody else who has family members, loved ones, neighbors, friends who are aging and want to age in place with dignity. And everyone is going to experience some unpaid caregiving role. And so we have to figure out a strategy to make sure that our older adults are able to stay in their homes and age with dignity. Our regional consortium on healthcare workforce, we co-convene this with FLIX. We have been working together since 2018. The consortium was commissioned in 2016. And again, this brings together leaders from multiple sectors. We have healthcare, we have educators, we have community-based organizations. Our state and regional economic development folks are at the table, businesses, health insurers. And what we're trying to do is help everybody understand that the health of our community is directly tied to the health of our healthcare workforce. So your regular Joes can't go to work if they have to worry about their mom or their dad aging at home. The purpose of our consortium is to meet the region's need for healthcare workforce, to improve the health of people in our region, We focus on 3 strategic areas. Skills. So we're always assessing the skill needs of our workforce, competencies, and are there training opportunities to get that workforce skilled up. We're looking at processes, staffing needs, gap analysis, changing roles, need for new roles and new technology, as well as capacity of our pipeline programs, our workforce diversity. Are we eventually going to get to a place where our healthcare workforce actually represents the population that we're serving? And again, trying to bridge that gap between what the employers need and what our educators are putting out. Underneath all these strategies is our cross-cutting strategy around effective workforce development policy, information sharing, and leveraging new and existing funding across sectors to bring all of us together and make sure we're moving in the same direction. I'm going to pass it to Katherine.
Thank you, Melissa. I'm Katherine Rogala. I'm a white, Caucasian, tall woman of Eastern European descent, and I'm wearing a white and beige blouse with black slacks. So I'm with Flips. Much easier to say than finger lace performs slides. We are a not-for-profit organization formed about 10 years ago, made up of 20 professionals supporting a network of 100-plus clinical and community-based providers. We work together in what's known as the Finger Lakes region to transform the system of healthcare delivery by specifically bridging the gap that exists between community and healthcare. And we do that through innovative programs and services, in large part funded by CMS-approved Medicaid dollars. The Finger Lakes is made up of 13 counties. And given the vast geography that we serve, we divide it into 4 subregions, which are highlighted here on the map, to ensure that care is provided at the local level to the community. Our administrative office is located in Rochester, New York, and our team has vast experience in network and program and project management, care management, population health and data analytics, evaluation, performance improvement, and importantly, workforce development. Not work. Press the arrow. Thank you. We successfully led the implementation of a complex and large-scale program from 2015 to 2020 in the Finger Lakes region. The program was referred to as the Delivery System Recorded Set of Payment Program, or DSRIP for short. The goal of DSRIP was to improve the design and delivery of healthcare services for the Medicaid population. Again, this program was governed by an agreement between New York State and CMS under the 11th Waiver. We became recognized through this effort as an implementation engine in our region, and working collaboratively with our vast network, a region-wide clinical quality committee, we achieved impressive results for the DSRIP program. The total investment in this innovative program and services associated with this program was nearly $500 million. And overall, we achieved a 21% reduction in potentially preventable admissions and a 17% reduction in readmissions. Where are we today? We continue to drive transformation in our region, and we have strategically aligned our work across 4 pillars, and this work is cross-cutting. 4 pillars are community programs, supporting partners, Greater Rochester Health Home Network, or GRIN, and workforce. The transformation efforts that we lead and are proud to be part of continue to be achieved through collaboration, partnerships, expertise, and importantly, execution. Under the community programs, supporting partners and workforce, we recently completed 20 projects involving more than 30 partner organizations over 3 years that integrated community-based care into healthcare delivery systems. These projects impacted multiple domains, impacted behavioral health, maternal and child health, care management, and social determinants of health. I'd like to highlight a few of the projects that advanced health equity. The first is the community-based doula program serving Black and Brown women in the city of Rochester, the urban area, and in the rural migrant areas of the Finger Lakes. We partnered with an FQHC, community-based organization, and Health Connect One to provide a 3-month training, and importantly worked with both the FQHC and the community-based organization to develop a job description for a doula. And through district funding of about $1.5 million, this money provided funding to these organizations to be able to recruit and hire and pay doulas full-time while they provided doula care. nearly 300 Black and Brown women were served, and maternal and newborn outcomes have been better than local, regional, and state reported outcomes. Of importance, the organizations are continuing to provide doula care and are continuing to employ doulas full-time. And it should be noted that New York State Medicaid, starting last year, provides for a doula service visit. Another project that advanced health equity was a maternal home delivery program. This program was done in partnership with 2 regional food banks, and these food banks either coordinated and or delivered the fresh food boxes to birthing individuals and their families. These fresh food boxes were delivered during the pregnancy and for a period postpartum. And importantly, diapers and other supplies were also made available to these birthing individuals and their families. Upon enrollment in the program, a welcome package, pots, pans, utensils, cooking oils, and spices were provided to program participants, not to assume that they had the required tools to be able to make nutritious meals at home for their families. Also, under the community program supporting partners in workforce, we are currently supporting a program that focuses on the long-term care sector and rebuilding its workforce to be able to take care of and provide high-quality care to older adults, care that they deserve. The program is funded largely through the American Rescue Plan Act and also taps our expertise as we are a New York State designated workforce investment organization. We prioritize the long-term care sector for workforce programming in that it is experiencing critical workforce shortages and faced with nursing staffing mandates. And additionally, Medicaid rates for skilled nursing facilities are woefully outdated and insufficient. Medicaid pays for over 75% of nursing home care in New York State. These factors are contributing to nursing homes' inability to fully staff their licensed beds that they're licensed to operate, and thus not meeting community need and presenting an inequity issue. Our workforce programs are true collaborations with healthcare providers, higher education institutions, training organizations, and community-based organizations, as well as engage with minority and women-owned local businesses. We co-design these programs with these stakeholders to recruit, hire, and train individuals to begin a career in healthcare and to provide opportunities for advancement in their career in healthcare. So individuals initially enter the healthcare career through entry-level positions like home health aide or certified nurse assistant. Our programs are designed to provide equitable opportunities for underemployed, unemployed individuals, mostly women and minorities, to address the critical need for nursing positions in long-term care. An important feature of this program, and I believe that it sets it apart from other programs, is that the employers are committed to hire individuals without the prerequisite certification. They're not yet qualified for those jobs, but the employers are willing to hire and pay these new employees during the training, which could go from 3 weeks to 8 weeks, a wage as if they were an employee. And employment is contingent, of course, upon the completion of the training program and certification. Importantly, individuals are assisted with transportation, childcare, tuition and fees are covered, and whatever else they may need to be successful in that training program, and importantly, in the new job. There are over 1,400 individuals that have entered a career pathway through our programs. And these programs provide additional educational opportunities at no cost, provided that these individuals pursue these additional educational opportunities to become LPNs, to become RNs. This will lead them to will provide for economic mobility, increase their family income, and importantly, lift their families out of poverty. These programs have already produced over 1,000 home health aides, certified nurse assistants, 300 licensed practical nurses and registered nurses, and there are another 100 LPNs and RNs who are currently enrolled in education programs. So where do we find these individuals? We employ many recruitment strategies, including we launched a health career website with job postings. These job postings are at local skilled nursing facilities, at home care agencies. We have a recruitment campaign underway that includes radio ads, paid social media, digital, and earned media. The ads target the 18 to 24-year-old demographic. We also developed a digital recruitment toolkit that is provided to community-based partners, organizations who do the outreach and engage with the populations that we're trying to engage in these workforce development programs. These organizations are trusted members of the communities that they serve. These community recruiters are extensions of employer recruiters, and communication channels and pathways have been established for warm handoffs of prospective employees. Looking ahead, we are very excited about what is next for New York State as it relates to 1115 waiver. The New York State Health Equity 1115 waiver is an amendment to New York's existing waiver. And this waiver was approved at the beginning of the year and goes from April of 24 to March of 2027. The amount that has been approved is almost $7 billion. New York State will use this waiver to advance health equity, reduce health disparities, and support the delivery of health-related social needs. New York is planning on achieving the goals and objectives of this waiver to be achieved through targeted and interconnected investments in three primary areas. First, new regional social care networks will be established that will coordinate screening for all Medicaid beneficiaries. And depending on the results of that screening, linkages will be made to community-based services to address those health-related social needs. The state issued an RFA earlier this year. That RFA was due in April. Proud to say that Flip submitted an application and is a lead applicant for what we're referring to as the Finger Lakes Social Care Network Collaborative. And this collaborative includes existing networks. So in our region, we have 3 existing networks already, and our proposal is to bring all 3 networks together to form one unified network. Those networks include Together Now, 360 Collaborative Network, which is already using the Unite Us referral platform, and an IPA referred to as FLIPA. New York also plans to make a significant workforce investment, over $650 million, and engage 3 workforce investment organizations in New York to administer a career pathways pay program. We're very excited about this, given our workforce programs. There are nearly 12 healthcare job titles and degrees that will be funded. So New York State is very prescriptive as to what educational programs will be funded and what funding will be made available to students in these programs. But what is included are various nursing positions, including NPs and PAs, behavioral health positions and titles, and public health workers, including community health workers. Additionally, in population health, funding will be provided to financially distressed hospitals, not-for-profit hospitals downstate. There will be enhanced primary care payments, new substance abuse disorder programs, continuous coverage for children 0 to 6, and an independent statewide entity that will work with all the stakeholders among all 3 investment areas to ensure that we're collectively advancing health equity in New York State. So there's so much more to come as it relates to 1115 waiver and its impact on health equity. And hopefully next year we'll be back to share some of the impact that this waiver has had on New York. We have included on the next slide additional resources. Sorry, you can't see that. But we do provide a link to the New York State DOH presentation on the 1115 New York Health Equity Reform Waiver, including a recording of a presentation. Thank you. Thank you.
Yes. Thank you so much, Katherine and Melissa, for that presentation and for all the amazing work you're doing. Our next speaker will be from California. Her name is Kristine Nixon, and she is the Chief Operating Officer of the True North Housing Alliance and also the founder and CEO of AIM Solutions, which provides policy, design, and technology services for the Center for Medicare and Medicaid Services. Thanks. I get a clap already.
So it's starting out well.
Yeah, hello. Thank you for having me. I have so much to talk about in only 15 minutes, so hopefully I don't talk too fast. I need to go ahead. All right. So I am with True North Housing Alliance, and we are primarily known for being a full-service shelter. And I have to say, though, our mission is not so much just to keep people in the shelter. Our mission is to move people into permanent housing. So we do an awful lot of wraparound services that I'm going to be talking about. But the biggest thing that I'm here to share with you is our experience enrolling and operating in the CalAIM program. So for those of you who are not familiar with California and the 1115 demonstration, it's called CalAIM, and I'll get into that in just a minute. But I wanted to share a little bit of that with you and also some lessons learned that we've had. So I live in Butte County, and True North Housing Alliance is located in Butte County. I actually live in Chico, California, which is a really great place. So if you haven't been there, come visit. But Butte County is fairly rural. It's Northern California. California is a big, big place. And we have about 3 larger towns in California. In 2018, one of our 3 towns, Paradise, California, yes, that's actually the name, we had a really bad wildfire. In fact, it is today the most destructive wildfire in California history. And within a matter of 8 hours, the entire town of Paradise was evacuated and 56,000 people were displaced. 90% of all of the structures, which included mostly housing, were lost in the fire. So I live in Chico, which is right next to Paradise. And when that event happened, people who had homes that they could afford in Paradise really had nowhere else to go. So a lot of them came to Chico and also surrounding areas in Butte County. I want to let you in on a secret if you didn't know this. We've got a big housing problem in California, but let's just keep that just between us. So things like these wildfires that are happening in California actually are making the situation a lot worse. And there's something interesting that happens when there's been a natural disaster. It drove up housing prices even more than what they had been. And even 6 years later, this November, we're still dealing with that. And the impact that that has on the shelter is that all of a sudden, we now have 40% of our population in the shelter is senior. And we have such a demand, and we cannot supply everything that's needed for the unhoused in our communities. So I wanted to show you a little bit. True North is an overall organization. I mentioned that it's a shelter, but we provide a lot of services that are full service shelter. We have a navigation center that we're constructing where it is a no wrong door. Anybody that walks in there that needs services can be connected to behavioral health services. If they need a place to stay or a meal or an address or laundry services, that all happens in the shelter. But we also do vocational training and digital literacy, and we have a full program. In Chico, we have one of the California State Universities. So believe it or not, there's a staggering number of homeless university students. And so we help them with rapid rehousing, or any family in Chico that may have lost their home. We try to make it so that they don't have to stay in their car and they have somewhere to go in the meantime while they're trying to get permanent housing. So California, the 1115 waiver is called the California Advancing and Innovating Medi-Cal. And there are really 2 main categories of services that I should have flipped these, because the services that were highlighted on the prior slides all fall under what's called the community supports. There's another really big track that's ECM, or enhanced care management. There's also like a justice involved track as well. But prior to CalAIM, a lot of counties were involved in some pilots that were very similar to CalAIM. They're kind of the springboard to CalAIM. Butte County was not one of them. So all of this was very new to us. And they are all administered through the managed care plans. Well, if you were in one of those pilots, you didn't really have any relationships with the managed care plans. We certainly didn't know anybody there. And a lot of the folks that I work with at the shelter didn't know even how to get a hold of anybody at the managed care plans to figure out what do we do to learn about this process. So we started combing through information, and there is no shortage of information. I've never
been short on opinions. In my opinion, it's a little bit too much information because we've got DHCS is great. They have a website, but there's also collaboration groups, and there's a technical assistance marketplace, and there's the managed care plans are out there with their folks, and they're also have their own website. And then we have foundations and all sorts of things. And it can be really hard to figure out what's the source of truth, when something changes, which one is correct, and that kind of thing. So I commend them for having so much information, but I have to tell you that our staff that work at the shelter, I mean, a lot of them have been residents themselves. And the amount of extra bandwidth that folks who serve in these roles have is just non-existent. As you can imagine with the shelter, there are all sorts of things that go on, from fentanyl overdoses on, unfortunately, a regular basis to, just anything you can think of happens. And so it's daunting, to say the least, to try to figure out where to start and what's the first step and what's the second step. We don't care about 10. I'm just trying to get from 1 to 2 and 2 to 3. So I wanted to also share that there's a couple of major funding sources. In fact, there's no shortage of funding. The funding is fantastic. The managed care plans ultimately provide the main funding once you're enrolled, and then you can bill and for the services that we're providing. But there are a couple sources of funding that are supposed to be helpful for when you're implementing. The timing on that was a little backwards for us. We didn't quite get the implementation funding until we were already enrolled. But nonetheless, I think there was a lot of really good intention there for how to help these smaller community-based organizations get set up in CalAIM. One of the things that I did in my intro, I don't know if you caught this, but I also have a business that I started 6 years ago, and we do a lot of contracting for the federal government. So I thought, I understand the government. I understand the policy. I can read through this stuff. I've read it for the last 25 years. I thought I could help True North implement and go through all of the paperwork. But one of the things that I wanted to do, and I had some folks from my company help me with this, it's not meant to see. It's much, much longer than this. But this is actually a map of the entire user experience that happened walking through the process, all the way from the beginning of the enrollment through to now we're participating in the program. And I wanted to make sure that we documented what we thought the process was, and where things broke down, and where there was duplicative information, or where something stopped or stalled for us. And I wanted this to be able to have this kind of a conversation today. I think there is so much good policy, and the intention is wonderful for benefits, but there's a bit of a breakdown when we get down to the ground floor on how to implement that. And there's a lot of low-hanging fruit that I think could be addressed really easily to reduce the burden on these smaller community-based organizations that are literally just thinking about how to house people. And we provided over 120,000 meals last year alone. You have to have somebody show up every day for all 3 of those meals to cook and serve. My family and I do that, and it's no small task. So we documented that, and I wanted to conclude here with just a couple things that we've learned over the last year and a half. We had a number of challenges. I mentioned that the information was hard to keep up with, but that's okay. There's things that you can do to streamline that content that's not that hard. We also had a cultural and language barrier. The managed care plans are dealing usually with our traditional providers. Well, guess what? Like, our community-based organizations need to become our new non-traditional providers. When we can keep people off the streets and give them the safety of a place to sleep with a meal and some dignity and a path out of where they are at that moment, they're not going to end up in the emergency room. It's work with the basics is to have safety, and these people don't have safety when they're out on the streets. So we are an absolute critical part of our healthcare system. And so we need to start involving the community-based organizations early on in the process when policies being created, because we don't speak the same language as traditional provider community, or what,
these community-based organizations aren't always speaking the same language as the federal and state governments. So we don't have a way to estimate the time and expense. I think our organization was, the fact that I'm standing here, I'm on the board, I'm incredibly supportive of our executive director to go through this process. But a lot of them don't have support of the board or other people that they rely on to say, hey, this risk is worth it. I have to tell you, this CalAIM program is a sustainable business model for us. It is a game changer. It was not an option to not go through this, no matter how much it took. We are a nonprofit organization. Every year we had a cliff that was coming 2 months down the road, and we would have to decide, do we lay off half the staff? At what's the trigger? What's the point that we do that? This gets us out of that. And I want to talk a little bit more. I have some other recommendations and things in here, but I can't wait actually to get to the next slide. I'm jumping ahead of myself. So another thing that's just kind of a big one, there's no real mandate on having to share data in a county or community or among the managed care plans. So you can't tell if a managed care plan is paying for someone else from another community-based organization. Well, ultimately, those are going to show up as duplicates, and somebody's going to get the denial. So those are things we're still working out the kinks, and I know California cares tremendously about this DHCS, but we need a way to address the data and the lack of visibility of data earlier on. I mentioned a little bit about what helped our organization succeed. Our executive director is amazing, and she did have some familiarity with being a Medi-Cal provider, which really helped. That can be so intimidating for somebody who's not in a medical field or involved with all of the requirements that are needed to be a Medi-Cal provider in general, not just Medi-Cal. But we also had the belief that this is more important to us than failing here. We had to give this a shot, and we were going to. We also developed relationships with other community-based organizations. And to be honest, the peer network was the most helpful thing that we had to be able to help us succeed. And I stand like too close to some. Sounds like grain, but it's just although it could be a repetition. And then we had also, in the managed care plans that we worked with, we had a single dedicated point of contact. Unfortunately, the managed care plans that we were working with when we implemented just transitioned to another managed care plan in January. So kind of had to start the whole thing over, but we were better at it this next time. So 2 times around, we had a lot of practice the very first time. This is a slide that I really want to impress upon you. This program has had an impact not only for us as True North, as a community-based organization in Butte County, it has had an impact on our entire community. I mentioned a little bit before where we didn't have stability, so we didn't know if we had to lay staff off in a couple months. We're very transparent with the staff, so they knew that as well. Well, guess what? They don't leave anymore. They're here, and we have lower attrition rates because they know that there is sustainability and they can see a path forward. This program, in giving us sustainable revenue, has also allowed us to go to banks, and like the interest rates on our line of credit before were terrible. And we barely could even use a line of credit. They're coming to us now, offering us more lines of credit because they see books with sustainable revenue and a plan. And we've been able to build on that over the last 9 months of being enrolled in the program. We also have donors that are coming out that see us as a legitimate organization. The shelter's been here for 25 years, so this isn't new. But what we're able to do now with all of these wraparound services, we're going from being known as a shelter to a place that gets people off the street permanently and works for permanent housing. That's a lot more than just the shelter, and there's a lot more that goes into doing that. But we've been able to do that, and the whole community is seeing us in that regard. Butte County also, there's a shortage of jobs, and we've been able to provide more jobs. Most of the residents, I think I may have said this, but unfortunately, most of the people who work with us have been residents at some point, and it gives them a path forward. So
that's allowed us to do all of that and then some. So it's been an absolutely incredible game changer and a lifeline for us. And we just every month try to think about how can we do more and more to serve the community, get where we need to go. And that's all I have to say about that.
Thank you so much for that really insightful presentation. Next, we're going to be hearing from some folks at the Duke-Margolis Institute for Health Policy in North Carolina, as we'll be learning about the Healthy Opportunities pilot. Our first speaker will be Katie Cooper, who is a senior policy analyst on the healthcare transformation team. And we'll also hear from William Bleser, who is research director of the healthcare transformation for social needs and health at the Duke-Margolis Institute.
All right. How's everybody doing? Good. So Katie and I are going to split this presentation. We have a lot. And awesome to see the actor robot. It's very, very cool. So my name is Will Bleser. As you already heard, I'm a research director of healthcare transformation for social needs health. Duke University's Margolis Institute for Health Policy. We're actually half in DC and half in Durham. Sounds like the DC area. I am a white man. I use he, him pronouns. I'm wearing, this is harder for me to do. Let's see, gray suit pictures, green and blue plaid tie, and then blue socks with watermelons on them, which my 3-year-old will tell you it's his favorite food. So okay, so what is North Carolina's Healthy Opportunity Response? Here's the 10-second version, and this is intentionally obfuscated. So NCHOP is 1115, where PHPs, which are MCOs, and NLs, which are CCHs and HSOs, and CMs, which are RNs, work together to address major incidents. So and at that, it is the biggest that I can explain that the quickest. So what it actually is, through a Medicaid Section 1115 waiver program, many people consider this the most expansive Medicaid program to address health-related social needs. And in many regards, it was the first to do it at its scale. So a lot of people are watching it. It was approved in 2019, and although it didn't actually launch until 2022 because of some budget delays and then because of COVID. And they created a 29 service social service fee schedule, which was the first one officially in Medicaid. And those 29 services cover food insecurity, housing insecurity, transportation, interpersonal violence, and some cross-cutting services like legal supports. The entities that I mentioned. So this is a $650 million total allocated program. $550 million of that is reimbursement for those services. $100 million of that is upfront funding, or some of the entities with all described, to build the capacity to do this. Noting, as heard from some other speakers, that a lot of times these entities have never worked with Medicaid. They've never worked on cross-sectoral technology platform. So it's a lot of work to get there to do that. The PHPs I mentioned, prepaid health plans, those are Medicaid MCOs in North Carolina. They're ultimately responsible for the health, right, and they're at the risk for the cost of members. Their primary role in this program is actually the screening and enrollments. So this is folks who have an identified social need and a chronic illness that are living in roughly a third of the state. It's being tested in 3 different parts, and they can be on services. They employ the care managers, which are the nurses, the CMs I was referring to, who do the screening and enrollment. The delivery model is primarily through Community Care Hub, CCH, which the program calls network leads. And the network leads are regional organizations. Most of them are historically care management entities that are responsible for building a network of the CBOs that deliver those services. They also sort of do training and technical assistance. And some of that capacity building funds went to them to help build up new staff to do this, to work with Medicaid, sometimes for the first time, to run those trainings. But the majority of that money goes to the CBOs. There's about 150 of them spread across 34 counties that cover these 29 services. And they use that funding to do things like hire staff, get new office space, sometimes getting vans, go to trainings, travel to conferences to get together, stuff like that. And yeah, that's pretty much it. So that's the whole program. Any questions? All right. So today we're going to talk primarily about the housing component of it. Katie's going to talk a little bit about what the services are. We have been working to support this initiative for the past 3.5 years, working closely with the state, some folks in the room here. So, yeah. And we are working mostly on sort of a robust qualitative evaluation. I think we just hit our 100th interview, which is pretty cool, but we've also been doing convenings. We've had some focus groups with actual recipients of the program, and we were watching partners. And so I'm going to be brief on the slide. I want to kick it over to Katie. We're going to talk about a line of work and a paper that we just published earlier this year, specifically on housing services, which is probably no surprise the most complicated part of the project, at least according to the years. Katie.
Thank you. Good afternoon. I'm Katie Huber. I'm a senior policy analyst at Duke-Margolis. I am a white woman. I use she, her pronouns, and wear a lady blue suit. So like Will mentioned, we're really excited to really dive into the housing aspect of this program. We spent a lot of time really diving into the design and implementation of the pilot's housing services, which we will talk through today, but also encourage you all to take a look at the Health Affairs article that we published earlier this year that has more information on what you found.
Oops.
I meant to do that. So as Will mentioned, there's the several domains of the called really like social needs services that the pilots address, but within the housing domain, really able to address a wide variety of housing related needs, which we categorize into 3 categories for simplicity. But the first is really housing navigation case management, which really supports enrollees in finding and maintaining more stable and long-term housing. The second is housing quality and safety modifications, which can address issues in someone's home related to safety and accessibility. So can include things like pest eradication, mold removal, accessibility modifications, and things like that. And then the last is housing and utility cost mitigation, which are services that are provided on a more short-term basis that can help cover the cost of housing. So for an example, first month's rent at security deposit. Okay. So for an overview of our study, we really wanted to learn about the lessons and insights from the design and implementation of the Healthy Opportunities Pilots housing services, really to inform other states and federal policymakers who are addressing housing-related social needs through Medicaid at scale. As we heard today, there's a lot of states that are working on this, and CMS's guidance around this is evolving, and so really wanted to identify what could be learned from North Carolina here. And so to do this, as Will mentioned, we conducted a lot of interviews and stakeholder convenings, and also some focus groups with recipients of pilot services. And then we also analyzed quantitative data on the services that have been delivered through the pilots so far, as well as some census tract level data of housing problems, to just get a sense of the landscape and how the pilots is addressing those needs. And from that, we identified 4 key themes that really highlight cross-cutting opportunities to address housing and Medicaid, and we'll talk through each of these in more detail. So our first theme, this really shows the results of a lot of our quantitative analyses. We describe how the housing landscape in North Carolina varies both within the 3 pilots regions as well as across them, and that has important implications for the way the housing services are delivered through the program. We write about these in a little bit more detail in our article, but for some examples, the 2 eastern regions of the pilots are more vulnerable to hurricanes, and so we heard, not loud enough. Sorry. The 2 eastern regions are more vulnerable to hurricanes, and so we heard that creates unique housing challenges in those regions. We also heard in the western region, there's a higher proportion of homes that are older and so has had some quality related issues. And we found that really the housing service delivery through the pilots has been able to be responsive to those needs. We analyzed data from the American Community Survey on housing problems, really categorizing that data into housing availability, housing quality issues. And we found that the Western region had the highest percentage of tracts with quality issues, which are shown in the map in orange. The Southeastern region, in contrast, had the highest proportion of tracts with availability issues, which are in dark blue. And then the Eastern region, we found had the highest proportion of tracts with both issues. So you really see how these the housing issues across the state can really vary, and you also see some variation within those regions. And then in figure 2, we really saw the way that the pilot's housing services have been distributed so far has been responsive to those needs. And so we really found that the importance of really defining housing services flexibly to be able to meet a wide variety of needs related to housing that can exist within a state. Our next theme is really on how to define and price housing services. We heard that this is very complicated from our interviewees. And so we heard, for example, that a lot of the housing services are very flexibly defined to be able to meet those range of needs that we heard, which people appreciated as it really allowed folks to address the needs that they were seeing. We also heard some challenges with this, specifically when it comes up to pricing. The housing domain in the pilots contains some of the program's most expensive services, which is great to be able to meet needs in that way, but also heard that some caps on some services are still too low to really address folks' needs in their housing, and also really reflect the true costs that CBOs were incurring to provide these services, and especially in the context of things like inflation and the house market. So we also heard that it's really important to balance this flexibility with quality guardrails to make sure folks are receiving high quality housing services. I think incorporating health-related social needs into quality measurement, as you've heard throughout this conference, is a relatively new field, but there's definitely opportunities to measure the quality of housing services and also incentivize that high-quality service delivery. And then we also recommend that states really think about balancing this flexibility and accountability in their programs, really being able to design and modify their programs to be consistent with the evolving guidance in this field and also meet the needs of their members. And so I will pass it back to Will to wrap this up.
Quiz time. Here you go. And bike. I wanted to mention something that I forgot to mention on the intro slide, which is what are the results so far? Because people are just in that overview. There's been about 385,000 social need services delivered so far across about 2 years. I mentioned again the program expires this October, but they submitted a state renewal to not just continue for another 5 years, but expand it statewide, add a couple of new services, and out. So you can across the year figure that one. And results from the services, they have statistically reduced ER visits, reduced inpatient admissions, reduced unmet health-related social needs. And what is this translated into? This is just as of a few weeks ago, this report came out. If you look at how much money was spent on health services and these social needs services compared to if the program was not there, so folks in counties that don't have that, $85 less per person that's adding in the social service, so precinct and advantage order. But I wanted to talk about the financial model here because there are some sustainability challenges. Katie mentioned the most expensive service domain. One of the services has a $10,000 authorization, and this is a reimbursement model. It's a CBO fee schedule. So you are asking if all these CBOs have to be North Carolina based. By the way, only 3 are statewide, so the other 150 or so are smaller grassroots. They would have to be able to front for one person a $10,000 check and then wait 60 days for reimbursement as a challenge. It is nice to have the transparency of the fee schedule to know, exactly what you're going to get paid and what the definition is. And that does have its upsides, but that means that there needs to be a cash flow supplement. And so part of the capacity building fund says $100 million. They actually were able to flex to authorize to float some of that. And then there also was one of the 3 network leads worked with a local philanthropy to create a zero interest credit to float as well, something they're interested in scaling. I wanted to also note on the financial sustainability, one of the networks also created a business solutions center. So that is specifically to train CBOs on being financially sustainable, understanding how to do a budget, how to take their profits and reinvest them back into their business and expand. So that was an interesting thing to note. And in the future, sort of a recommendation, when you're thinking about how to finance this, everything has a trade-off. I mentioned the transparency of a fee schedule. And for some services, where it's harder to define the service. You don't necessarily know how much volume is going to come in. It's nice to have that. But for other services, it's probably better. It's the service is more predictable and more easy to define, like it may be a food box or housing repairs, to have a prescriptive, right? So that you're not having to front $10,000 and wait 60 days. And that did cause some CBOs to have to turn off their service as well, even though they had the capacity to, yes. So we recommend looking into hybrid payment model. When we heard CMS earlier talk about their flex model, where they are actually in the MSSP looking at paying HCOs or provider groups on a fee schedule while also giving them PMPM monthly costs and be something to look into. And then lastly, challenge of working with different stakeholders and the complexities of housing. So relative to other services, housing services often require a sequence of things that have to happen. Inspection is a service, is a prerequisite often to some of the supporting the first month's rent or doing some housing repair service. And then in other cases, having the housing case management is a prerequisite as well. And so from a CBO perspective, you might ideally want a CBO to be able to do all of it, but then you're going to leave out some of the grassroots CBOs. So that's an interesting challenge. And you probably need to think about, if you're designing these programs, how to sequence or how to get CBOs that work in tandem or maybe that sub out or roll to the CBO. And then lastly, I just wanted to note some challenges around working with new stakeholders for the first time in Medicaid that would be unique to housing relative to other limits. One would be working with a third party that has legal rights for the service that you are providing, which is a land, right? Mm-hmm. So that is not something you commonly encounter in Medicaid. And some of these home repairs require authorization from the landlords. And some of the agreements that the state was initially working required that the rent not be increased as part of the agreement. So that was a lot of landlords were walking away from that. They did end up dropping that, but just doing that for folks that might be designing or implementing these programs. And then contractors. So when I say CBO for like food insecurity, a lot of times you're thinking about a mom and pop food box operation, a nutrition case management. In housing, you do have some of that, but then you have private construction companies. Like, who's going to do that's different. They're used to operating a commercial market. They're used to having their own pricing. And so that is challenging. For them to work within this fee schedule, they had a tough time maintaining the workforce in some counties. And one example we found where it worked out really well was a construction company that had already worked in a HUD program. So it's a little bit used to some of those prices, but that's something to think about. All right. Lastly, I just wanted to note, thinking about linkages across the housing sector and how to sort of build these relationships to make stakeholder engagement easier. HHS, CMS, and HUD launched this Housing and Services Partnership Accelerator Program this year. They selected, I think it was 9 states. North Carolina was launched. And this was a continuation of the program they did just many years ago that ended, I think, about 5 years ago. So that is a program, if you are a state or a stakeholder interested in doing this work, your state Medicaid agencies, sometimes the state HUD agencies and the feds are all working together to try to build and these networks and training these folks. So look into that program, very good. So I am going to, for time's sake, end there, but here's our contact information. Please reach out to us and look forward to this end.
So he's fantastic. Was he also a tall, except in
the stand behind me.
Stay united.
Well, unfortunately, we only have about 5 minutes to fund. We can go over like few more minutes. Does anyone have any questions? Person at the back in the blue.
I did it for you. Can tell me. Yes, more. This for the virtual.
What about this?
Okay.
Very quick question. First of all, thank you for the presentations. We work a lot with 1115 and we want to learn from your experiences. Knowing what you know now, what you want to, or something you will advise us not to do so that we can become better.
Please, you. What state are you in? They're all very different, I think.
You are going to California, so all this quote. Right now, in states, the plan is to go through all the mandates.
I can start. I can start. I would say that, and this conference really brought that to light. There are so many resources and subject matter experts. And so I would just advise that if you're starting something new, seek out, be resourceful, seek out others that has maybe done the work already and meet with them and learn from them. I was just so impressed with all the work that you've all done and thinking about how you might be great resources to us as we embark on addressing housing insecurity under the 1115 waiver.
I'll just add briefly, do not offer upfront funding. The most common thing that we heard was you need upfront fund. You heard some of the specific reasons like floating cash, but also just preparing a system to work with another system they've never worked with. Section 1115 Medicaid waivers are one of the few ways to federally finance that. Otherwise, you might be reliant on grant programs or organization.
So those dollars also need to be easy to access, and the process has to be doable. I mean, for us, ultimately, we ended up enrolling in CalAIM before we ever got the implementation dollars. So it was an investment of cash that we didn't have. So it was a huge risk. And I think it's working out for us, but it can't be so difficult to access those dollars up front that it's not worth it. No, none of these organizations, I think it's probably safe to say a lot of these nonprofits, they do not have extra cash laying around to be able to hire the people that you need to hire. And also the IT systems, you had to get a third-party biller and, all of that kind of stuff. So it was a lot of money up front that we didn't have. See, any other questions? The gentleman there. Which way?
She would like there's lots of.
Any question?
Hi there, Nils Franco with ATI Advisory. I'm curious if it's, in general, an interaction that you encountered where any entity in the Medicare program, whether that be an ACO or an MA plan, kind of is interacting with these payments being made under Medicaid for the same individual.
I think the question is do we interact with Medicare program?
Right, including MA plans or ACOs?
We don't. Medi-Cal. So CalAIM is strictly only those Medi-Cal recipients are the folks that we can. We have a lot more. Well, not a lot. About 75% of our population is nationally in the Medi-Cal program anyway. So we do have duals. We have elderly population, and then we have BA. But for the most part, this is the only program that pays for our day habilitation, housing deposits, things like that.
North Carolina, I would say we've tried to learn about more of the landscape of what's happening with MA and other programs. I think there's definitely some efforts to try to learn from and coordinate with one another. Although I think kind of across the board, Medicaid is usually the payer of last resort, meaning usually the other programs need to be used before Medicaid will go in and fund that. So I think that's kind of been a challenge in making sure that folks can get the services they need. But
I would just add the commercial payers are going to be the space where you see that. Programs don't formally interact, but you might have two plans running, a special supplement for supplemental benefit from the chronically ill MA social need program in the same county that they might also be one of the MCOs running HOP. So I just wanted to.
Yeah, I was just going to say, we anticipate working much more closely with the MCOs under the new 1115 Health Equity Reform Waiver.
Great. I have time to make one or two more questions.
So I could I'm most curious about, probably less so for people that are engaged with housing, temporary housing, but as you're engaging with patients, maybe it takes a while to get into housing. They're not necessarily at a shelter. How do you keep them informed in the loop, right? Instead of having healthcare happen to them and support happen to them, how do you make sure their voice is still heard and a part of this whole process if it takes those weeks sometimes?
Well, I will answer because our case managers are the linchpin to this entire organization. So whether we turn people away at the shelter because we don't have room. So we still have a case manager. Our caseload is 30-1. So we have 30 people to every one case manager, but they will stay with that person until they're housed and then a year after they're housed to make sure that they retain housing. Time's up. I'll show you.
Now recorded 20 hours for but you guys can stand. If people have questions that you still want to ask, our speakers are welcome to stay up front, and you guys are more than welcome to talk to their station. We've had it up on that. You have a ticket, red.